Welcome everyone. My name is Anne Livingston and I'll be the chair and moderator for today's webinar for the Community Care Smart Assistive Technology Collaborative. Today's webinar is on Smart Assistive Technology, driving changes in the management of continence. This webinar is part of a series being facilitated by Community Resourcing for the Community Care Smart Assistive Technology Collaborative. At Community Resourcing, we use our national and international expertise and networks to build community capacity through empowerment, knowledge transfer, skills enhancement, and importantly, research and development projects. Community Resourcing has been funded by the Queensland Government to bring together an online platform for providers who are interested in collaborating on issues and practices related to incorporating smart assistive technology. We were very honoured to be awarded the ITC Innovative Entrepreneur Award of the Year at ITAC for this project. Today's session has been actually oversubscribed again, showing the high level of interest in incorporating innovation into practice. As attendees at today's session, you will be on mute, but we encourage you to ask questions through the question pane on the right of your dashboard. And at the end of the session today, there will be an opportunity for these questions to be answered. Any questions that are not answered in the time frame that we have this morning will be answered online on the Community Care Smart Assistive Technology after today's session. Today's session will be delivered by Leonie Mulheran. Leonie is an expert in this field and has worked for over 18 years in community and aged care areas. Leonie first graduated from QUT and then worked at the Royal Brisbane and Wesley Hospital before taking on various roles as educator and moving on to, at a very young age, to a role of state manager in a private company. She's been working managing Continence Aid's assistance scheme for departments such as Department of Health and Ageing and the DVA RAP scheme, and also been managing contracts extensively for the Medical Aid Subsidy Scheme. Since July 2011, Leonie has had the pleasure of working for Simavita, using her experiences of the past, but creating new horizons with this great Australian innovation. This Australian innovation is rare that it's exporting an Australian-developed product to the world. In today's session, Leonie will discuss how smart assistive technology is driving radical change in the management of incontinence. Welcome, Leonie, to today's session.
Thank you very much, Anne. I really appreciate this opportunity, and for those service providers, this is a very important part of the everyday work of care workers and your clients in their lives at home. And I think one of the things that comes out when we talk about continence is the prevalence is very high and the impact on the workload, and as a service provider needs to be top of mind throughout each day, but also in the coming years more so. We're going to be talking about today the prevalence of incontinence. It's not just in the ageing population, it's also in the young. We're going to talk about the role that smart assistive technology can play for the service provider and the consumer in the continence care in the home, and the economic impact and the future possibilities that you have as a service provider. Interesting, when we look at the statistics for the younger generation, the 3 to 5% of children who are aged between 5 and 17 have a daytime wetting problem, with 1/3 also experiencing bedwetting. For those of you who have disability and work in the disability area, the incontinence levels can almost be 100% in those with disabilities, and obviously this is actually the general population, these percent results here. The day wetting is more common in girls than boys. However, boys have more bedwetting issues than girls. It's very genetic from families, so a mother and a father, if you both had bedwetting as children, you're more likely to have children with bedwetting issues as well, or even just one parent. Now, both of the problems, whether it be bedwetting or daytime wetting, tend to improve with age, but children don't necessarily grow out of it either. 1 to 3% of children experience soiling or fecal incontinence, but they also may experience wetting as well. As you can see, as we get to the older generation, the statistics do get a lot greater. 13% of the entire Australian men population have urinary incontinence that affects their life, with 37% of Australian women. 70% of it, and this is where, as a provider, understanding that 70% of the people that have incontinence have never actually sought advice or treatment. So coming into your service, you can expect that 70% of people have never had any advice or assistance with, and they've actually managed on their own in different forms. Fecal incontinence is also incredibly, it's actually worse for men in Australia at 20% and 12.9% of Australian women. 70%, this is back in 1995, and since then the rates of incontinence in Australian nursing homes has actually risen with the level of care risen. But we look at in CDC or community care clients, it's without a doubt 50% of your clients have a significant incontinence issue that needs your care and advice. Looking at the prevalence, the amount of people actually in the population in Australia with incontinence, you can see the differences between 2010 right up to 2030. We're actually going to reach about over 5.5 million people with incontinence of urine and close to 2 million people with fecal incontinence. Now we look at that statistic and it's quite horrific. If you had that many people with wound care problems who had major concerns with their health in different areas, you can see why incontinence at the moment in the past has been left as the last thing that is addressed and last thing that people talk about. But in fact, actually it's becoming a major medical issue that actually needs to be addressed and will affect you as service providers. Incontinence is one of the major 3 causes of being admitted into residential aged care. I know that's one of the goals as a provider, to reduce the speed at which that happens for quality of care at home, but it's actually incontinence and mobility and dementia are the 3 top reasons why they would go to residential aged care. Restoring or improving incontinence becomes critical for you guys as a provider. And one of the greatest things about bladder and bowel is that you can actually improve the incontinence by using the individual's natural bladder pattern, and that is a very exciting proposition, because when you use a device to determine a bladder pattern, you can actually create a fabulous toiling program and change timing that will actually assist them to use their natural bladder pattern rather than trying to change their natural patterns. Interestingly, for male clients, for a lot of us, we understand that it's quite difficult to manage continence. For male clients, that can be for social reasons. It can be for the fact that they have never worn a product to maintain any sort of leakage before. For males is very difficult, but they also have difficulty with the movement of private parts during the night, and so often at night it can become a major issue for your male clients, but also their partners as well. So significantly with males, it is obviously a big risk factor for compliance at times with products, and there's lots of different avenues that you can address with them as well and help them. For clients that have incontinence, there is actually a 3 to 6 month wait in the community for continence assessments. Now, when we look at the actual wait time for that, it's because there is not enough continence advisors in the community to manage the millions of people that do have issues, and that 3 to 6 month wait, obviously with not enough funding but not enough clinical providers. What that means is, as a health provider and a service provider and actually caring for those with incontinence, it's important to actually manage the bladder and be able to give some very baseline assistance and care, and then referrals on after that. If they have to wait for that 3 to 6 month period, unfortunately what that does, and it is definitely a paper-based bladder chart that they use at that point, it isn't a medical device, it's just a piece of paper that they go and sit with a continence advisor. The continence advisor takes a couple of hours sometimes to actually understand and subjectively write down everything that they can actually gather from either the client or their family. But waiting that long to get to that point, it means there's a major health risk for their health deterioration, for falls, skin irritation, breakdown, overuse and incorrect use of products. They're often on much bigger pads than they should be, or actually the wrong product. Carer stress burnout is a big issue with depression, anxiety and isolation. And again, the early admission into residential care. Nurse carer worker family visits to the house. This is important sort of management for health providers out there. The timing of coming to the house at the most debilitating times of the day would have to be one of the areas of focus when it comes to continence management, but also utilising the client's funding, whether it's the inefficient timing of visits or whether it's actually product wastage through the funds that they have, or through the continence aids assistance schemes such as CAPS and MASS. Improving health obviously is a really important part of our role as health providers, supporting their sleep, reducing their soiled linen, but preventing those risks we talked about when poor continence management is actually received. So why does, I guess ultimately when we talk about regular toileting times, we talk about quality of life and health improvement. One of the things we discussed just very briefly was falls. With clients in the community, there is a major link between incontinence and falls. It is widely acknowledged. It needs to be on our risk assessments when we actually assess clients, because as they're getting over 70, that incontinence leading to falls is actually much, much greater. So that's another high risk factor. On top of the higher level of incontinence that they have, the client has a much higher, again, risk of falls on top of that. When we looked at why, obviously you look at someone going to the toilet, all of us with a very full bladder, it's incredibly urgent. We rush to go, our heart rate starts to increase. We start to get stress and anxiety around that, and we'll often forget to do the natural things such as hold on to rails, being slow and careful to get to there safely. So the risk is much, much greater. And unfortunately, when we look at the statistics of injury-related or premature deaths in aged care, it's 80% were actually from falls. So the prevention of falls in the home, I know that's on our top list of priorities, but we need to have the continence level listed as a high risk and do some preventative care. Now we can have alarms, we can have different things to alarm us when someone has fallen, but what we're talking about here is actually managing their bladder well, so they're actually preventing the fall in the first place, which is incredibly important. There are other things that you can, as a multifactorial intervention, you can use hip protectors and nutrition and hydration and all different things to assist with their falls. But one of the things we need to look at today is how we can do that with incontinence management and determining the right time for toileting and changing. So the current manual assessment process, as I've mentioned below, previously, is that it is a 72-hour process where they fill out a piece of paper, writing down when they're wet, when they go to the toilet, and when they're drinking. It is actually quite manual, and often there's lack of motivation, so often comes back to the continence advisor quite empty. What that means is for our clients, when they actually go to an assessment and they do get finally assessed, it's quite unreliable, that information they've recorded inaccurate. It's labour intensive, there's very poor compliance, and is quite disruptive to have to write down everything that's happening constantly throughout the day. So how do we meet that need in that assessment process? And we looked at, obviously we're talking about today is technology that meets this need. We really needed, and very early, late 90s into the early 2000s, we wanted a benchmarking system or a device that provides better quality care and efficient treatment of incontinence. And by doing that, the solution was to develop a remote instrumented monitoring and reporting system to facilitate that continence assessment process, to make it a lot faster, but actually more accurate with real medical data for a medical device. So how does that work? The SIM incontinence management system, or SIM or Smart Incontinence Management, is actually a combination of things. It's actually a 72-hour continence assessment process again, but it has an automated bladder chart that's actually created from the client wearing SIM sensors during that 3-day process, and in those SIM sensor pads that they're actually wearing, it actually is censoring when their bladder is emptying and recording it each time. It's actually real time recorded onto their bladder chart, so we can see when their bladder is emptying. From that, the toileting times and the continence aid selection is based on real evidence and real data. There is an app and a mobile device that the carer or the client or the nurse can actually utilise and record data, and together they can actually really ensure they have an accurate assessment to improve incontinence. The components that actually the client is wearing, they're wearing a SIM sensor pad, which has a sensor strip through the center, and on the end of that, as they're wearing it, there's a little pod that's actually connected to that, and that pod is actually checking every 4 seconds if there's any wetness events that have occurred. Then they're wearing a pair of special SIM pants that has a special pocket for the pod to ensure the client's comfortable during the assessment, and they get 3 pairs of pants for those 3 days, and they have 10 SIM sensor pads that they're actually disposed of. The SIM pod itself, between assessments and after the assessment, goes back into the dock for charging, but uploading all of the data and all the wetness events. The wetness events that you can see on this chart, I'm just going to look at the first SIM assessment on the right-hand top of the slide. You'll see the blue drops on that chart. That's actually the wetness event of a client wearing a SIM sensor, and you can start to see as you go from day 1, 2 and 3 when their bladder's emptying, to understand when their bladder pattern and when they're the best times for toileting, the best times for change, and being able to understand that client's bladder. What that does is, with this first, and I guess being a first instrumented continence device, it identifies those bladder patterns, but ensures that we're actually reducing unsuccessful toileting as well, and they're going at the right times. The change times are really important, but it allows your staff to actually either enter the home or actually give the client specific times by either messaging or a directed plan in their bathroom that they can follow each day. In the SIM plan implemented, I just want to make note, when you actually are looking at there's app data that's actually superimposed across that, and you can see when they've been drinking, you can see when they've actually gone to the toilet, you can see when toileting's working. So as far as the app goes, that actually is data that's collected during the assessment as well. When the SIM plan was implemented with their new toileting times and products, you can see in the second chart the reduction in blue drops is significant. This is exactly what we're aiming for each client, to improve their bladder management by reducing the wetness events. It's essentially, we want more in the toilet and less in their product. That way they can wear a lot smaller product, they can actually go out at different times of the day that are more appropriate, and they can actually be cared for at the times of the day that are most vulnerable. This is just a little picture of the app at the moment, the Sim Assist app that we have on our devices that the staff are using. It is too complicated for our clients, so we're actually reducing it down to maybe 3 icons. And that's a development that we just started on the process of working with a provider in Brisbane and Victoria to actually look at what clients really are able to use on an app-based program. So at the moment our nurses are using, the nurses or care staff coming in are using the app, and the clients in the very near future will be using the app themselves. When we look at falls prevention, and I mentioned earlier that falls is a really interesting, I guess, a major part of what we do because it is such a significant health event if it does happen. Castlemaine Health actually have done a small study in Victoria last year where they actually had 16 clients, residents in an aged care facility, where they were actually measured the 6 months before they had a SIM assessment for their continence and measured after the 6 months after they had their SIM plan implemented. They've had a massive reduction in falls for those 16 clients alone, and has had a major impact on the Castlemaine's health direction and how they manage falls in the future. So the community care, and from a community care provider, what does this mean for you? And I guess this is a very important part of why incontinence needs to be on your agenda each and every day for care staff, but also for your clients in their care and their managing and planning for their care. What this does is gives them a very client-directed care, a very focused on assessment that's actually specially individualised to them. There is significant savings in their CDC funding, whether it be through products or timing of care provision, and the waiting time that they have can be brought down from 3 to 6 months to 1 to 2 weeks. And that's a significant change in health direction for someone who's actually been struggling, sometimes even up from 10, 20 or 30 years beforehand. The family support and compliance, we find that with clients doing a SIM assessment, you'll find the assessment is a little easier when you've got family support and compliance. This doesn't mean you can't have an assessment done on a client that doesn't have support at home. They can quite easily do the POD application, but it does help. And someone with dementia and that sort of those different health issues, it's always good to have a bit of family support or a carer going in at least once a day. What this means is, as a provider, you'll be able to provide them with a sim bladder chart, which is the medical data. Product recommendations come out of the system in mils, so you'll be able to advise them on the product that will suit them morning, afternoon and night. You'll be able to give them a product style recommendation with the toileting and change times. The referral that you may actually decide at the end of the assessment might be required, you can actually refer them onto a health professional when there is other needs such as bowel management, medications, possibly even retention or issues with fluid and hydration, etc. You can do some referrals after that. Then you can confirm the new plan with the client and provide product requirements and access to products such as samples. It is also good to look at that SIM plan 4 weeks post-implementation and make sure that what you've done is actually working, and review that with your client. Some of the interesting, when we were looking at our client pilots that we have done late last year, and we're actually in the middle of one at the moment, we've actually seen some very differences in what our expectations of what the amount of volume of fluid they're even losing. And so some of these results we're just touching on today. Look at the average pad weights that they're actually utilising. 58% of all the clients, their pad weights were under 200 mils in weight, which is a very small glass and a small bladder full. It's actually quite a normal bladder full for a client, but it's actually interesting that only 11% had pads that weighed over 500 mils, which is 2 bladderfuls. So products that they were wearing are often up to 2 to 3 litres in capacity, and this gives us a very clear indication that our clients are over padded and should be actually utilising the products and changing at the right time of the day so they don't need a pad that is actually in excessive size. And again, 32% were in that 200 to 500 mils, which is light to moderate absorbency. When we looked at clients that actually had a SIM assessment and actually utilising their product, now they could have been purchasing it through their provider and using very large products. We do have clients in our next assessment run of our pilot that actually have been purchasing from pharmacy or grocery stores, and the products they're using have been adding up to something like $4.90 a day. And on a pension, you can imagine, and with the scheme funded where they're only given 2 to 3 pads a day, or under CDC, that money doesn't go very far. And after a SIM assessment, these first 5 clients were either reduced their size of their product, or the type and style was adjusted to suit them, so they didn't need to use 4 or 5 pads a day, and they're actually on the right product for them. One client was actually proven to be completely dry and gained her confidence and realised she could actually go out and not be worrying about wearing products 24 hours a day. Another client, as in client 5, you can see was actually proven to be on the right product and stayed on that right product, so she was very confident that she had what she needed. There are times where we're seeing clients aren't on the big enough product or the right style and have to spend more each day, but that's preventing leakage, falls and other health issues as well. So it's very important to look at it not just as a product saving project, it's actually much, much bigger than that. When we look at the economic impact that we have on the overall cost of incontinence, I guess ultimately the government has a very big part of it. They pay, that was 19.8% of the cost of incontinence per person, looking at federal schemes. Under the personal scheme, they did lump the state-based schemes into that. However, the state-based schemes in some states actually don't exist, and they actually do have to provide their own. Queensland's very lucky with the medical aid subsidy scheme in Queensland. In other states, it's quite limited. But the cost that it may actually break the hip, it could be their capacity to work, it could be their capacity for their family to work in being a carer in home, as well as product and so on. The cost increases, and I think this is significant for each provider to record and understand their client base, is that we're starting off at the moment, the health system costs, obviously we know they're going to increase by 2020 to over 450 million just for the incontinence in the health system. But when we look at actually what you are doing on the ground with your packages and care provision, when we look at these results which came from the Continence Foundation of Australia, we found that for each packages they recorded over 87% needed assistance with incontinence. Now that for us, we know that over 50% need care and carer work for a care provider, but there's still a lot of people who do wear light products and still need advice and do have lighter issues, but there's 87%, which is very significant. And under CACPs, it was 18% at the time in 2010, and HAC obviously 11%. But we actually really, I guess, from a health provider, need to understand each of our clients and identify their incontinence needs to be able to provide them either very preventative care in the early stages, but also then provide more clinical care as their needs change. Now, the role of technology, and ultimately technology can touch on a lot of these different things, but specifically to SIM, and actually having it's simply for us, when we look at it as a medical device company, it's more like a blood test for continence, where you can actually create the data that you as health providers can actually utilise and actually refer on, but be able to provide many different benefits, such as greater care plan compliance. So clients actually know when it is actually suitable for them to go to the bathroom. It could be staff awareness and engagement, so that they're actually identifying earlier when your clients need help. It could be optimising staff resources, such as the road trip that they take each day to each client could be reorganised to actually benefit the client's actual individual needs. It can reduce UTIs by them wearing the product at the right time of the day and less infection. Reducing skin breakdowns. The skin breakdowns with incontinence pad use in the community can be quite significant, because clients do try and save pads and wear them for longer than they should, and it can cause issues with skin breakdowns and obviously the volume and capacity of urine. The contribution to falls reduction will be significant in the future. Compliance in the future as well, and risk mitigation. As a provider, we need to think very clearly about, have we done enough to be not just recording falls but actually preventing them. Marketability, and all of us as providers right now need to think about our marketability and having a device and a service that actually brings awareness to you as a company by having technology that makes a difference to people's lives, that has a huge marketability opportunity. Reducing continence aid costs is a given. We look at reduction in unsuccessful toileting, and we look at that from a very clear angle, is if your clients are emptying their bladders in inappropriate times, 20 mils, 10 mils, 15, 30 mils, their bladder capacity will reduce over time and will worsen significantly. We want them to be emptying the bladder at really good times of the day with 100 mils, 150, 200 mil capacities, and to do that we need them to go at the right time. So this is really looking about maintaining their bladder capacity and being able to give them a longer time at home with their family. The evidence that they need for ACAT assessments, another one that's a real tricky one. Often people go into aged care with ACAT assessments with incontinence unknown or undiagnosed. This allows for that to support the ACAT team as well, and improves quality of life, dignity and comfort, which is something that is an ethos for all of us in the community area. We had a couple of about 5 or 6 providers come together and look at what SIM did for them, and successful toileting in the aged care sector, where they've got care staff all the time on the floor. Their success rate for toileting was, the unsuccessful rate was 40%. So every time they took someone to the bathroom, it didn't work. And when we looked at that as a huge industry issue, when we're talking about in the home, we've got carers that are coming in when you take them to the bathroom, and when you're doing this work, you've really only got one shot at it every day to get the right time. So let's see if we can improve the success rate around that for the client and their family as well. The reduction in product cost comes from changes in style and the volume and capacity that clients are wearing. They're wearing pads that are way too big that they need, so the product capacity come down. It does affect the environment, what we're disposing each year, but also the client and comfort wearing a smaller product as well. So the future possibilities for providers providing continence assessments clients, you could do that within a week or 2 weeks, and that's a very real proposition. You can reduce product wastage or incorrect ordering of continence aids from schemes, which when they get their product, it's for 6 months. They don't have to wait for another 6 months to get the right product if it's incorrectly ordered. Maximising the client's funds, improving the overall health and well-being of your clients, giving clients hope and guidance on how to manage their bladder and bowel, which is often their last dignity that they have, and it's a very, very, very of high importance to them. And you can provide services possibly to your greater community. Don't just think of your clients in your care, think of the greater community in your region. And again, the improved marketability that that would have and risk mitigation would also give a lot of I guess, a greater using technology for the greater good as well for your particular company. And so just a little bit about the invention. I know that Anne's actually discussed very briefly that it is an Australian invention, and being a part of that, I guess, and the development that it's actually gone through. In the late 90s, the ideas were coming from, the developers, but in 2004 was the first funding that the Australian government, Commonwealth government grant that actually provided the funds to have a clinical trial of the concept. So in 2004 was when it was first, had funds behind it to actually to bring it to fruition. And in 2008 was when it was realised that after 4 years of testing and trialling and prototypes, and was able to actually start commercialising it. In 2010 they actually launched softly to the market so that they could actually make improvements before the 2011 Australian commercial official launch. And since then we've had a number of different things in the US. 2012 it was released and launched, and since then we've had a couple of generations. We're on generation 4 at the moment, which was released in 2013, which was obviously a big change for us because we were actually approved under FDA in the States, not just in TGA in Australia. And then in 2014 we were able to roll out in the EU as well, under their medical device legislation. So very exciting for us being able to not only bring a product from Australia into the world, but being first out there. In Australia we have got so much potential in our community care provision, and this is, I guess, for us is the start to the community care use of SIM, and we look forward to a very exciting year in 2016.
Thank you, Leonie. That was a fantastic presentation, and particularly it's great to hear how smart assistive technology is really driving independence for consumers, but also driving more appropriate care and practice. Thanks for everyone who's contributed to the presentation today, and I've got a few questions on board at the moment. So firstly of all, I've got Doug from Gundawindi. So welcome, Doug. Doug indicates that thanks, Leonie, for a very informative presentation. I work in rural and remote communities, particularly with younger people with a disability. I'm very keen to understand how we might work on using technologies like this, but particularly within a research context. And thank you for your comments about research that's already been undertaken. But he's also interested, Leonie, on whether you use technologies like telehealth and video links to link with providers like Doug in rural communities.
Yes, thank you, Doug. I think one of the things we've done over the last 6 months is we have had some pilots that have been underway, and we're just about to finish our last one. We've got 2 more coming up in April with providers testing the product. We're obviously incredibly interested in looking at utilising the product in the disability sector, so I'd be very, very keen to talk to you further. And being in the rural areas, we do need to use such things as ClearC or face-to-face with that for not just training, because we have online training for the SIM training part of it for our care workers and staff using the SIM device, but we also need to do that for support during the assessment and so on as well. So we do have customer service, but more and more we use face-to-face. I agree, it's a very important part, but disabilities is something that we actually definitely would like to do some pilot work. And as we discuss and we go through how the device is at the moment, the device has been in the residential aged care for some time, and we're just doing some very initial starting to looking at the actual product is how it actually works with our clients and looking at simplifications that we need to do. So over this year, a part of our research obviously is actually making sure the product is appropriate for client use in the home and making those changes. So we'd be very interested to obviously talk to those with disabilities and clients that need to be assessed and how we can actually provide that.
Thanks, Leonie. I've got another question here from Penny. Penny's from Port Douglas, and she's saying, thanks, Leonie, the timing of this webinar for us was very appropriate in that we've got a number of issues with our client group. In Anne's introduction, you showed that you had extensive experience with continence aid schemes. Are you able to give us a quick overview of what some of the opportunities might be to get assistance for our clients? And our clients are predominantly younger people with disabilities from the age of 50 to 65. But also, could you please comment about how smart assistive technology like SIM might be funded or incorporated in existing schemes? Thank you.
Yeah. At this time, there is actually different schemes that your clients can access, and there are federal schemes as well as state-based schemes. In Australia, there's the federal scheme, which is CAPS, the Continence AIDS program, and that is actually done through Medicare. So it's actually a form that can be completed. There are different disorders and diseases, and under that process, when you actually go through that application, there's different ones that are actually approved under that scheme that are either if you've got a pension card, and those who don't have a pension card, there's other disorders that also are approved under that scheme. And that'll be around the $500 and so on every year. It does change with the CPI, and that actually is paid to the client to actually fund some of those products. In each state, it does vary. I would advise to, depending on the state that you're in, if we're in Queensland, yes, Port Douglas, but for those of you who aren't in Queensland, we need to you need to go to the Continence Foundation of Australia. They have the list of all the state-based schemes and the access points for those schemes to understand those. In Queensland, for Port Douglas, you need to go through the Medical Aid Subsidy Scheme, where they have to have a full continence assessment, and they have to have permanent incontinence, and they will actually access up to 2 pads a day. Now, if they are in the younger age group, for the younger children with disabilities, they get more than 2 pads a day, but once they're actually in the adult bracket, they're actually down to 2 pads a day, and they need to access the CAP scheme as well in Queensland.
Thanks, Leonie. That's great. We've got encouraged people in the audience to continue to post their questions on the pane to the right-hand side of your computer. We've got a question from Rachel. Rachel, you're asking for some more information about costings of using this product and others, and how would we go about looking into using it?
Yeah, and the funding of this is obviously important from Penny as well, in Port Douglas. When we're actually doing these pilots, one of the things we're actually having to look at very closely is getting the product to the client. We haven't got exact costings at this point. We're getting quite close to it in the next 2 to 3 months. We think we'll actually be able to provide that to you, Rachel. It is actually important to understand the cost to getting services to the clients. It is different to what we're supplying to hospitals and nursing homes at the moment, because it is into clients' homes, and also the funding's very different depending on what service you're providing. When it comes to CDCs, it can be a service that's provided under the CDC model that is charged through yourself. So we're actually putting together a process that helps from a client's perspective, that you're able to charge a certain amount and we can provide the device to you. If it's actually under the schemes and for continence, it is actually a medical device. It has not been approved under any state government scheme yet. However, we will be hopefully applying for such things as DVA RAP scheme to be able to get access to that as well. For those of you, I did miss out the DVA RAP scheme earlier on the national schemes. For those that have a gold card or a card under the DVA RAP scheme, they can also apply for products under the DVA scheme for continence aids. So that's another avenue as well if you've got clients who are under that banner.
Thanks, Leonie. We've got a number of people on the line who are already collaborating on the Community Care Smart Assistive Technology collaborative platform, and a number of them have raised questions around positioning for the National Disability Insurance Scheme. And in particular, they're interested in what opportunities as a collaborative that they might work with you as an Australian provider to look and test how this smart assistive technology might work within the National Disability Insurance Scheme. Many are very keen to work collaboratively to position themselves, but also to provide better services to clients that they serve.
There's a question here from John asking for advice on how directly working with consumers, and that's what we're doing at the moment, is to set up, John, we're looking at having a very clear direction as to how we actually have that process. So we're mapping that process out at the moment. We're very close to being able to provide that to you. So if we could keep in contact, we'll be able to work with you in the future and work through that process with you and many providers who are keen to understand the best way to get this service to your consumers and be able to provide them with the care that they need urgently, but then also that referral to the health professional.
Thanks, Leonie. Look, we've got some more questions coming through, and thanks, John, for your response online there. I'd encourage you to keep your questions coming. Leonie's going to be in the room for a while after today's webinar, but also if you post your questions on the Smart Assistive Technology Collaborative, she will answer those questions. This is a really important subject, and obviously from the economic analysis undertaken and the analysis of how big an issue it is in the population, we know that there's real opportunities to drive change through the use of smart assistive technology. So we thank Leonie very much for her time today, and from the crew from Simavita, who are really importantly trying to really make a difference and empower consumers and care providers to provide better practice and better solutions to ongoing issues. I'd also like to acknowledge that we've got some more upcoming webinars for people on the site. Our next one will be looking at how smart assistive technology is assisting with mobility issues, and we're particularly going to concentrate on some emerging technologies around exoskeletons. We're also going to then concentrate on some of the work that we've been driving within a team here with the assistance of students from QUT Allied Health, and where they've been driving improvements in nutritional status through the use of smart assistive technology. Our first webinar in May is going to concentrate on the issues around worker safety, and particularly when in community care workers are working remotely for considerable parts of the day. And I'd encourage you to check out those webinars at the link www.smartsatcommunity.com.au, and at the same time, if you haven't registered for the platform, you can register your interest in being part of the platform on that site. There's a number of people to thank for today's session. I'd particularly like to thank the project team for their collaborative, and also the members of our external expert reference group. We've got a number of contributors both internationally and nationally to that expert reference group, and they're working behind the scenes really diligently, providing assistance, advice and support for the development of the platform. In particular, we would like to acknowledge the funding of the Queensland Government. This is a great initiative by the Queensland Government, not just contained to Queensland. So our brief is to work nationally and internationally. The Queensland Government has recently, on the back of success that we've had and the level of interest we've had in the collaborative, extended our funding, but also provided great opportunities to increase our focus. And soon we'll be launching some information about a consumer portal within this Community Care Smart Assistive Technology Collaborative. I'd also like to acknowledge and thank today some audience that we've had from QUT and a range of students from QUT Allied Health courses. And finally, I'd like to thank today's presenter, Leonie. Leonie's been a great reputation in the sector for supporting sector development and capacity building. We know that she's really passionate about this issue, and she's passionate about improving people's lives with better technology and better care practice. So thank you, Leonie, for today's session. And I would also like to thank everyone who attended today's session. Again, we've been oversubscribed, so please watch out for the posting of this webinar on the collaborative, and people can access those and share it with others in your organisation. Thanks everyone, and we'll look forward to seeing you at our next upcoming webinar.